But kicking us off, we have a truly distinguished academic interventional radiologist. I'm delighted to welcome Professor Mark Little, who is a consultant interventional radiologist and also Director of Research within the Department of Radiology at the Royal Berkshire NHS Foundation Trust. He's a recipient of the NIHR Research Rising Star Award and currently leads on a European study investigating genicular artery embolization, which is treatment of osteoarthritis in the knee. He will be telling you much more about that in this talk. He's also a UK chief investigator for another international study, which is investigating long-term outcomes of prostate artery embolization. And he also is a specialist advisor to the NICE Interventional Procedures Program, and is also a member of the CVIR editorial board, which is the largest IR journal in Europe. So, Professor Little, thank you very much for joining us and look forward to your talk.
Thanks, Jim. Thanks, Indra, as well. It looks like a great program. And I think, I'm really passionate about interventional radiology research. So it's a real privilege to come and talk and hopefully inspire the next generation of IR academics, because it's extremely important. So I'm going to spend half an hour or so talking about why we should do research in IR. So can you see that all right? I'm just going to try and get that. Great. None of my disclosures are pertinent for this talk, but I always put them in. So let's start with a bit of history. And this chap is a vascular, or he was a vascular surgeon. So we can all start booing John Hunter, who was a vascular surgeon in the 1800s. Now, he was considered the founder of scientific surgery. So obviously, back in that time, it was fairly basic, the surgery then. It was chopping off legs and lancing abscesses. But he was trying to add a more cerebral element to the pursuit of surgery. And he was the first physician who was famed with treating an aneurysm successfully. In 1777, he wrote the True Principles of Surgery. And from that, there's an interesting paragraph, which is, I'm going to read, which is, this last part, namely operations, is a tacit acknowledgement of the insufficiency of surgery. It is like an armed savage who attempts to get that by force, which a civilized man would get by stratagem. And we fast forward 200 years, and this chap called Dotter arrives, who conceived of that stratagem, and he called it angioplasty. So Dotter was the civilized man that Hunter was talking about. I jest, but you can see how rapidly times have changed. So Charles Dotter, famed with being the father of interventional radiology, did his first case of dotterization, as he called it, or angioplasty, as we call it now, in 1968. So this is a really recent intervention. The first patient he intervened on was a lady with critical lower limb ischemia. And I want to play this video just to give you a sort of a flavor, really, of just how profound this intervention was. Hopefully you can see that.
In pain. All right, let's get started. Now the smaller inner catheter goes in and is advanced over the guide and down through the narrowing. Usually there's little resistance. Because of its safety, simplicity, and effectiveness, transluminal dilatation now qualifies as treatment of choice in the management of atherosclerotic stenosis. Its further improvement seems inevitable.
So I think, it's pretty phenomenal that since 1968, we've had the huge increase in everything that we do. And Charles Dotter was known as Crazy Charlie. He was a maverick, a pioneer. And he was a larger-than-life character who was also a bit of a celebrity. featured on the front cover of Life magazine in 1964. But he was also an academic, and I think this is really important because we sometimes think of interventional radiology as these proceduralists. We develop new things, we don't really focus. But he published more than 300 papers, of which he was first author on more than half, produced 3 scientific training films, and created nearly 20 scientific exhibits. So he really was an academic in the true sense. And I think that's often lost in the story because often people just think of him as being this maverick pioneer who had a quick wit and a sharp temper. But actually, without his ability to consolidate his inventions into scientific literature, we would never have interventional radiology. So really, I can finish my lecture here, because why should we embrace research in radiology, in interventional radiology? Well, actually, without it, we would never have interventional radiology as we have today. Because without his pursuit of publication, he wouldn't have been taken seriously by the medical fraternity, and none of the procedures would have been practiced on patients. And that's, I think, really the main take-home message of why we need research in IR. It's to protect the future of the specialty, to enable us to continue to develop. And in 2021, evidence-based medicine is everything, and data is key. So we talk ad nauseum about conflicts, about turf wars, about how we can't get access to PAE patients, to UAFE patients. Actually, all of that is born of the fact that we need to compete on a data level, on a research level. Because once we have large-scale level 1 evidence, it talks for itself. And that's the only way to get into guidelines and the only way that we advance interventional radiology, image-guided surgery as a standalone medical specialty. So we've got a great deal of gratitude to Crazy Charlie for his work pioneering IR, but more importantly, for his dedication to the research around those pioneering procedures. And he was the first to describe numerous things that we take for granted today. So flow-directed balloon catheterization, safety guide wire, the J-tip guide wire, which you'll use daily, percutaneous luminal transluminal angioplasty, stenting. He pioneered thrombolysis. He co-invented the loop snare, which he used to retrieve intravascular foreign bodies, which we do a great deal of. Developed the primitive embolization kit, and even organ ablation. So he develops a huge number of things. So why then is IR not seen as an academic specialty? You'll all be familiar with this mark, Interventional Radiology, inventing procedures for other specialties since 1973. And we are a victim of that in many regards. And I put the picture there of the coronary angiogram, because we as radiologists used to perform coronary angiograms, of course, in the 60s. And then the cardiologists have obviously taken that over. So why are we not an academic specialty? How can we do better? Well, it's because we're procedure-driven rather than disease-driven. It's because we're interested in new technologies and not long-term follow-up. We are the ADHD medics because we can't focus. We bounce from one thing to the other. We like the shiny new bit of kit. And we're problem solvers rather than data consolidators. Now, there's huge benefits in lots of these characteristics, but actually we need to consolidate. We need to learn from our mistakes and go forwards by embracing research at a high level, because then we can compete. And I put here the cardiologists example, who are fantastic at data. They're fantastic at multi-center, large-scale registries. And the part of the right slide here comes from the Gusto trial, which is a seminal paper published in Circulation back in 1999. And this was a global trial looking at the role of percutaneous transluminal coronary angioplasty, PCI. And so what they did is they looked at the 30-day mortality of this large-scale trial of those patients that had angioplasty within a timely fashion and those that didn't. And you can see the graph down below. Patients had a 14-fold increase in 30-day mortality if they didn't have PCI. So what? Well, actually, this is everything, because now every single hospital in the country has a cardiac lab and a PCI service. It's come on so far, and it's all because of data. So when you're going to present to your CCG, your board, and you want another cath lab, another consultant, actually this data is key because it proves that it's good for patients and we need it. So data is key, and this is all due to the joined up thinking of the cardiologists who are disease specific around producing data, in this case for PCI. So that's why research in IR is really important. But we're getting better. This is a graph of the number of publications in JVIR over the last 27 years. And you can see that there's been a significant increase over that time, and it continues to increase, which is reflected in the impact factor of the journal, and also in CVIR, which I review for. Why else should we embrace research? Well, competition. Now, many of you will be trainees, either at the beginning of your training or just thinking of applying to radiology. And this table comes from the 2020 competition ratios for application and entry to ST1 in the UK. And you can see that radiology is extremely competitive. So a ratio of 4.21, more competitive than anesthetics, emergency medicine, core surgical training, histopathology, pediatrics. Now, clearly, neurosurgery and things like sexual health medicine are up, but actually they've got very few posts, so the ratios are a little misleading. Nevertheless, clinical radiology is very competitive. But, and clearly there's debate around this, we're pulling from a large pool to try and get interventionalists out of. And we look at the American example where IR is a standalone clinical specialty, and you can debate this, but actually it's even more competitive. In 2018, IR was its own residency program, and it's still, since 2018, been the most popular competitive medical specialty there is. So more competitive than orthopedic surgery, plastic surgery, urology, neurosurgery, and ophthalmology by a country mile, 0.66 versus 0.88 with orthopedic surgery. So what's that got to do with research? Well, if you talk to American colleagues, actually it's being used as a discriminator. It's competitive in the same way that cardiology has done for many years. And that's a good thing, because to get into IR in the US, you need to be the best and brightest. You need the highest scores. You need to have done your PhD in IR before you even get to residency. And this will drive the field forwards. It'll mean that we can do these global trials because we're set up. And it's all about building track record, getting a track record, getting grants, doing more research, getting more funding, and showing our worth to the medical fraternity, to the research community, and to our patients. And so that's why I think competition is important to think about. So let's look at some other success stories specific to research within IR. Interventional oncology is a good place to start, and it's now seen as the fourth pillar of oncology treatment, and that's due to our embracing of data. So interventional oncology is now aligned with radiation oncology, medical oncology, and surgical oncology. So what? Well, it's important, again, as I said in the outset, because if we don't produce data, we're not going to be able to do our procedures on these patients. And there's good level of 1 evidence for ablation, SIR, TACE, for the treatment of oncological presentations for different cancers. And so we need that data to get into the oncology guidelines and care pathways, because without it, there's no way that we will be able to utilize the plethora of interventional radiology operations on patients with cancer. And that's important. The other important thing to mention is that we need to present data in a way that's understood by other specialties. Now, I said in the outset that we are proceduralists rather than disease specific. And I said that in a kind of negative way, but it's a positive way in many respects, because my day-to-day job is really interesting. I might do a nephrostomy, do an angioplasty, do some GAE research. So already in one day, I've done urology, I've done vascular surgery, and I've done orthopedics. So we cover a large breadth of subspecialization within IR and a large breadth of anatomy. And that's great because it's interesting. But it means that when we produce data, we need to make sure that we are talking the language of those specialties that we are trying to compete with. Compete is probably the wrong word, but we're trying to bring our data and our procedures into a space that's traditionally not had us in it. So not necessarily competition, but we are trying to provide data that those groups can understand, and therefore we can then try and bring that to patients. And the only way to do that, as I say, is with evidence-based medicine and getting that data to guidelines. And there was a nice paper in radiology which looked very much at this within the field of interventional oncology. And it was a consensus panel which identified the fact that study results were being collected, analysed and reported in many different ways. And we tended not to speak the language, the same language, as those within the field of oncology. So this paper was all about developing new research guidelines for IO that standardise treatment outcomes and reporting of data. Why is that important? It's important because in the future, what will happen is that our data will be incorporated into systematic reviews and meta-analysis. So I'll give an example. If you're treating a renal cancer with cryoablation, you want to know what happens to those patients. So therefore you pick an outcome variable, and that might be death, okay? So you want to therefore calculate the mortality associated or survival benefit associated with your intervention. So the way in which you report that has to be the same as the trials that have gone before it within the fields of medical oncology, radiation oncology, and surgical oncology. So is your ablation comparable or better or worse than partial nephrectomy for your 4-centimeter renal cancer? So unless you present your data in the same way as that surgical, you can't be entered into the meta-analysis, which will be used for the guidelines, which will define the European Society's guidelines on urological surgery for the practice of treatment of patients with renal tumours. So that's why it's important. What about prostate artery embolization? So this is, I think, another success story within IR evidence-based medicine. It's something that I spent a lot of my time researching over the years. And it's, again, like all of IR, very, very recent. So 2008 was the first intentional treatment for a human with PAE for BPH done in Sao Paulo with Francesco and his group in Brazil. Since then, thousands of patients have undergone PAE. But the important thing is that we have now captured that data. So we're capturing the data and informing it as part of literature. Sorry, does someone want to say something? Questions? No.
No, so I think we're all right.
Okay. So the benefit of the PAE data is that we are now getting better at reporting what we're doing in literature. And again, that's absolutely crucial for getting it into guidelines. All studies have demonstrated a consistent, significant improvement in IPSS. Now, prior to 2013, when I started research into PAE, I had no idea what IPSS was. And again, it's all about this notion of talking the same language. So it's the International Prostate Symptom Score. That's a validated questionnaire for interventions pertinent to men with BPH. And the urologists use it all the time. So we've had to learn that. And now it's part of my daily vernaculum. It's part of my daily conversation with patients who are coming to me for PAE. Also, urinary flow rates. Again, we've had to learn how to interpret uroflowmetry and urodynamics. So now I can go to, I write a letter. This chap came for PAE. His Qmax improved from 5 to 15. That's good. Again, prior to research into PAE, I had no real handle on what flow rate was. What's the significance of a post-void residual of 1.5 litres? All of these things we've had to learn and adapt, and all of it has come from our embracing of research into these fields. Last year, I was asked to give a lecture at Guest, and the title of that was, what's the most important PAE papers over the last 2 years? So I did a literature review, and it was heartening to find the sheer number of publications still on PAE. In the last 2 years, 113 papers. So that's more than one paper a week, of which there were 5 randomized controlled trials, level 1 evidence, and 8 meta-analyses and systematic reviews. So that's great. We are embracing research, we are adapting, and we are pushing forward with data, because that is the only way we can further the fantastic work that we're doing in IR. One of the papers I think merits special attention is the sham control trial from the Lisbon group. because this is really, the gold standard design for this type of intervention. And when we first started PA, there were a lot of urologists saying, well, this is just placebo effect, you're doing this intervention, and actually these guys are all getting better because of placebo. And absolutely, you need to consider the placebo effect. So this was a trial that did need to be done, and it was ambitious and difficult, but they did it. So this was a randomized, single-blind, sham-controlled superiority trial where they randomized 38 patients using a 1-to-1 ratio, and there was a crossover design at 6 months. So what that means is that patients in the sham arm at 6 months crossed over to the PAE arm, and these graphs are phenomenal, really, because what it shows is that there's significant statistical significance in all of the outcome measures with regard to PAE versus the sham procedure, and then with the sham procedure crossed over, they got better as well. So this is, a par exemplar of level 1 evidence carried out by this group. For those of you looking at this graph at the bottom here, thinking, well, there's no difference there. This was the International Index of Erectile Function. Again, another questionnaire that we've had to learn to be comparable to the urology literature, and there was no significant difference between PAE and sham, again, which is positive. So PAE superior to sham, level 1 evidence. The other thing I want to mention is where they published it. Now, it's not specific to IR, but we're quite good at the echo chamber of telling ourselves how great we are and publishing in the radiology journals. And that's fine. I'm on the editorial board of CVIR, so I would encourage you to publish there. But when we have data that is of this quality, we need to push the boundaries. So we need to be thinking about, going to the Lancet, going to big journals, big impact factors, because we need to sort of, drum up support and say, look, this is the work we're doing. Aren't we fabulous? It's really important because we are still, the minnows when it comes to research against, say, the oncologists, cardiologists, etc. This was published, the sham trial is published in European Urology, which again is great because it's right in the readership of the group that we want to tell. We want to say, look, this is this great procedure. Isn't it fantastic? Doesn't it have low side effects? Isn't it efficacious? And so they published it and the impact factor was 18.7. So that's good. And again, something I think we need to strive for, to get good quality data, level 1 evidence, and publish it in the disease-specific journals, leading journals for that area. What about UK rope? So again, this was prostate artery embolization, and this wasn't a trial, this was a registry. And every 5 to 10 years or so, we swing between, we need RCTs and we need registries. And we're kind of in a registry phase at the moment, which is good because it's real world data. And this was driven by Nigel Hacking from Southampton, phenomenal study. And this was 305 patients across 17 UK urological and interventional centres. And it included 216 patients who underwent PAE and 89 who had TERP. And the outcomes were IPSS, improvement at 12 months, and complications. So again, we know what IPSS is now. So it was used, and this was a fantastic study, and it was used as an example of good practice by NICE. So there was a NICE review last year which looked at rope as part of it was 50 years of NICE or 20 years of NICE, I can't remember. And it was used as an example of good practice. And from that, it led to a change in clinical practice. So again, embracing research leads to the change in clinical practice. So PAE went from a research only indication from NICE to it being offered on the NHS in a relatively short period of time, which was fantastic. And it genuinely was front page news. I remember reading the front page of the Mail in Oxford when this came out, and it was, fantastically exciting. And obviously, we've gone from strength to strength and have embraced PAE in a huge way within the NHS. Why else do we need to do research in IR? Well, it's important for patient safety, and it's important for our own learning. I mentioned and Jim's introduction that I am on the editorial board of CVR, so I have the great privilege of reading loads of papers. And I get to learn about lots of stuff I had no idea about. So research enables you to be a better doctor, I would argue. It enables you to keep abreast of new techniques, but it also enables you to consolidate knowledge about pre-existing procedures that have got longer term follow-up, and changing subtly the way we do things to improve benefit for our patients. This example is sort of an extreme example of that, but an important learning lesson, really, in that Katsonos published his paper, which was a systematic review and meta-analysis of data of patients who had undergone angioplasty using drug-eluting balloons. And he concluded that there was an increased risk of death following paclitaxel-coated balloons in the femoropopliteal region. So research led to a big, flashing red light warning about potential patient safety. And this was death. So this was really important. And it led to an NIHR investigation and a change in clinical practice. So this guidance, reissued in February 2021, says that following review, recommendations using paclitaxel in patients with intermittent claudication. So it says, do not use paclitaxel drug-coated balloons or drug-eluting stents in routine treatment in patients with intermittent claudication, as the mortality risk greatly outweighs the benefits. Now, this is changing all the time. So I haven't checked the absolute up-to-date data. So don't quote me and go back and say you can't use them, because there has been flux and lots of relooking. But I put this in here to illustrate the point of how important research is. So without that data by Katsonos, this debate never would have evolved. So it's really important that we engage with research, understand it, keep abreast of it, because it informs what we do and it informs patient safety. And that's clearly crucial to everything that we do as IRs. So I want to end by looking a little bit about my journey and where we've got to and what we're doing with genicular artery embolization, and finish with some conclusions, hopefully have a bit of time for some questions. So I actually started life as a physicist. I did an undergrad in Nottingham, and at that time I was there with Professor Sir Peter Mansfield, who won the Nobel Prize for MRI. And it was an amazingly fertile time for learning about MR and just seeing the huge acceleration in that technique. So I decided to become a medical physicist. So I did my postgrad training and research in medical physics. And I actually did the training program to be a clinical scientist and worked for 2 years in London as a medical physicist, where I had a body of research into functional MR, pulse programming for MRI, nuclear medicine and radiotherapy. Now, why is that important? Well, it's important because actually I learned a lot of transferable skills within basic science research, but it was also important because I understood the need for collaboration in research and identifying different groups and how that worked together to form translation. So from the basic science to getting these concepts of new MRI sequences to patients. So it was a really interesting time. And this was a paper that I did in 2002, so a long while ago. And this was looking at activation of the occipital cortex using visual stimulation. And it was using a new way of reducing scan speed, something called parallel imaging. And now parallel imaging is on all modern MRI scanners. So you'd be using, you definitely will have looked at scans where parallel imaging is used, because it can halve the time of scan acquisition. So we were using it in this context for functional MRI, which was a new area. And the more and more I did, the more and more I had exposure to radiologists, the more and more I thought, well, okay, if you can't beat them, you have to join them. I wanted to be in front of the magnet rather than behind it. So I went and retrained, and I suppose the rest is history. But from this sort of very early fMRI image in 2002, we go forward now to a rather beautiful fMRI image from my group in 2021. And we are still using fMRI, but in the context of pain. So in the context of the Genesis trial, which is a trial that I'm running for GAE, we're looking at neural connections in patients who have chronic pain from their knee, and trying to understand why some of those patients don't get better. So we're looking at the neural knee axis. And that's really, really interesting, actually. And I think trying to look at pain as an outcome variable is really hard. And so whenever I talk about GAE, I always try and assert that if you're going to research pain, it's not good enough to do a visual analog scale and do your intervention at day 0 and then do it again at a month and say, oh, look, it got better, aren't we? Great. It's a bit more complicated than that. So collaboration in research is crucial, and I can't take credit for that beautiful fMRI image in the previous one. That's from a chap in my group, Dr. Harrison, who is a psychology postdoc, who is a fantastic collaborator with myself from the University of Reading. So I just want to finish by touching on GAE, because that's something that I've spent the last 3 years researching, and it's something that we're really passionate about and really proud of what we've achieved as a group. GAE is a new treatment for patients with osteoarthritis of the knee. And the rationale for this work fits because there's this gap, there's an unmet treatment need between those patients with who have conservative treatment, so physiotherapy, weight loss, steroids, and those that have a knee replacement. So mild to moderate knee OA, resistant to conservative treatment, not yet severe enough to warrant joint replacement, represents a specific management challenge. And that's the rationale for all of this work, really. And I mentioned translational medicine because it is important. It's something I think as radiologists, we're really well positioned to do, because we develop all this fancy techniques and kit, but we need to make sure that we do the correct research to translate it to the patient. And as I keep banging on about, the only way we do that is through evidence and data. And these things take time and it's hard work. And it's not, let's do this, it's great, let's do it on patients. I don't think you can do that anymore. The days of that are gone. This is evidence-based medicine, and for that we need data and research. That's why it's important. That's why we need to do it. This paper comes from some of that translational work. So GAE is born out of the in vivo and in vitro data showing that new pathological blood vessel formation leads to the release of factors that sensitize nerves, cause destruction of the joint, and lead to patient symptoms. In this paper, rats were used, and they injected a specific angiogenesis inhibitor and showed that there was a significant reduction: synovial osteochondral angiogenesis, synovial inflammation, joint damage, and pain behavior. How you measure pain behavior in rats, I'm not sure. Another study, this time in dogs, again, identifying that, like with the PAE data of old, we started with animals and then went on to experiment with humans. And the dog model was used. And again, with this, they showed there was increased synovial vascularity and inflammation in the knees of dogs with OA. Again, elucidating this concept that embolization could be used as a potential target. The first paper for GAE in humans was in 2015 by Kunu, who, like Dotter, is very much the father of MSK embolotherapy. And you can see from this image from his paper, you've got the hypervascularity in the medial compartment here, which following embolization has gone. They embolized 14 patients, no major adverse events, and there was an improvement in WOMAC. And again, this notion of trying to speak the same language. WOMAC is the Western Ontario McMaster score. It's a validated questionnaire for OA knee, which is throughout a lot of the orthopedic literature. And following this, they found an improvement from 47 baseline, excuse me, to 6 at 12 months. So significant signal there. And since that time, there's been a number of studies, mostly cohort studies, until 3 weeks ago, where Bagler and Isaacson published their sham RCT of GAE, which is a phenomenal piece of work. So that was published October 2021. And this was a multi-center sham control study of genicular artery embolization for knee OA, where they showed quite small numbers, but they showed a significant improvement in pain and function compared to a sham procedure, which again, my hat goes off to them, because this is a tricky study design and something that we will be opening very soon with Genesis 2. We have our own randomized controlled sham controlled study that we're about to start, which I'm extremely proud of, and it's been a huge team effort, a lot of hard work. So finally, what's it all about? Well, it's about patients, isn't it, at the end of the day? And this comes from a bit of publicity we had when we did one of our first patients, which was focus of NIHR. And this was one of our first patients who was a golf captain who had the procedure and got some benefit initially. So it is about patients. It is about research. It is about getting data so that we can formalize what we do into guidelines. So what are the wider benefits? Just wrapping up now. Well, we get to meet like-minded academics and networking. You get dedicated time to spend on interests, because being a consultant it's a long road, and actually doing research is really interesting. I get dedicated time away from the standard clinical work to think about things, to look at things that interest me, and to meet like-minded people, and that's really really good. It's a really enjoyable part of my job, and I have specific time to do that. You've got the ability to travel and present your work. Publications make you competitive. As I say, there is going to be more competition for IR places in the future. Transferable skills, so networking, presentations, lifelong learning. As I say, my role as on the editorial board at CVIR, I thought, oh no, can I do another thing in amongst all the other things I'm trying to do? But actually, it's a really enjoyable part of my job, reading papers and learning about new things that I'd never even thought about. So that's good. Developing new treatments for our patients, I think, is why I do it. It's why I get up in the morning, because it's trying to make modern medicine better. There's no better specialty that's positioned than IR to do that. And then generating money for department and trust. And that's good, because you can reinvest and get another Angio suite, try and get another consultant colleague within my group. We've reinvested and got additional research nurse and additional research assistant, which has enabled us to do more and more work. But it's hard work. And combining research, clinical work, I've got 2 young children, it's challenging. Grants, ethics. It's, it is a necessary evil. It gets better the more you do, and it gets better if you have a good team around you that can help you. And I'm fortunate to have that. And it can be frustrating. You can research on something for years and years with a hypothesis in mind, and it doesn't quite work out the way that you thought it would. And not everyone will be supportive. So, actually, I'm lucky. I do have supportive colleagues, but I'm sure there will be times where they're saying, what's he doing, sitting in his office all day on a Thursday or on a Friday morning? And therefore it's important to highlight the things that we're doing, and that's something that I think something like today is really important to highlight to people the enjoyment that you can get from research and the importance of it for the furtherment of interventional radiology, image-guided surgery, and also to get all of the great stuff we do to our patients, very much in the same way that Dotter did in the mid-60s. So IR research is essential for our specialty to grow. It's the only way in which IR operations become part of clinical guidelines and become mainstream within modern medicine. We need to focus on disease, patients, and outcomes that are relevant to the domain of the operation. We don't need to just concentrate on technique, kit, and the new shiny device. And as I say, competition for IR is at a record high. So research will become a discriminator, I think, whether you like it or not, as with other specialties. It's good for patients, it's good for you, and it's good for your organisation. I want to thank you again for the opportunity to come and present, and hopefully, you'll be inspired by the other talks of the day to embrace IR, to embrace IR research, and make it better for future generations. Thank you very much.
Thank you very much, Professor Little, for that inspiring talk and for taking us through the world of IR and reminding us why academia and research are so vital to our development and advancement. I don't think there are any questions, and I have one question, if that's okay, Prof. What do you think is the most exciting area of IR research in the next 10 years, if you had to pick one?
Well, I think, so we're doing a trial at the moment called Target, which Indra is desperate to see, and I will invite him over at some point, which is using augmented reality to guide biopsies. And I think there's a lot of excitement within AR, augmented reality, and AI. I think we have to be careful, because there is there's a lot of bluster around that field as well. So a lot of people sort of badging, oh, this is AR, AI, to get grants and things. Not in an unscrupulous way, but I think we need to see the data and the quality of these new inventions and new techniques before we can totally say that they're going to revolutionize all we do. But I must say, from what I've seen so far of our early experience with the Target trial, which is using the HoloLens device to try and guide biopsy, I do think that that will have a role in aiding us. And obviously, you know, we are perfectly positioned as radiologists to combine the imaging to guide our intervention. So I think there will continue to be a big boom in that area. I mean, I'm kind of narrow in my area of embolotherapy. I think, you know, GAE seems to be going from strength to strength. So, you know, I registered it with NICE. I've had the meeting with NICE, and it's gone through its draft consultation. So, you know, who knows, if the data continues to go the way it is, then I see no reason why that can't follow the path of PAE. And, you know, it would be great to be part of that journey. So for me and my career over the next sort of 10 years, I think they're the two areas that I'm going to be focusing on.
We've had another question quickly come in, if I could just ask this to you. So Dr. Datta says, my vascular surgery SPR counterparts have incredibly robust research culture. Some of them are doing image-guided research despite not having formal medical training. So what are your views, Prof. Little, especially given the reported problems and conflict over the clinical work?
Yeah, I mean, look, you know, we're always going to get this issue of conflicts. And I think perhaps where IR's fallen down is that we are quite good at criticizing ourselves and being overly critical. I think, look, we just need to stand up and be counted. You know, we've got to embrace it, you know, and you've got to be brave. So, you know, if vascular surgeons are doing good quality research, fine, you know, so why aren't you doing good quality research? It would be my question. You know, I think, yeah, we've got to stop sort of hiding in the shadows and get out there and do it. You know, no, it's not going to come to us. We need to compete, and the only way to do that is you've got to be good. And it takes, you know, it's hard work. It's, you know, it takes a long time to sit down and write a protocol, go through ethics, try and get funding, get it off the ground. You know, if someone else wants to do that in another specialty, in something that we perceive to be ours, then they've done it. We haven't. So my message is we've got to get out there and compete. And the only way you do that is by, you know, spending time and working and doing this stuff. And I say that there's no real shortcut, actually. So, you know, I understand the concern and saying, well, you know, should they be able to do it? Well, you know, if you're both doctors in a space, you know, who's to say that you know, this idea of patient ownership, I think, you know, will change, actually. And it's about who provides the best intervention based on the best quality data for the best procedure for the best patient at that specific time. So, and, you know, that's why we need things like this to highlight that, you know, sitting around talking and saying, oh, there's all this conflict, and, you know, there is competition for, you know, to do PAE, etc. You know, it's always, I give talks about PAE all the time, and everyone always says, oh, you know, how do you get patients? So I say, well, we've got good quality data, and I have a very good relationship with my urologists, who are human beings and very good clinicians, and we work together, and I do the cases that are most appropriate, and they do the cases that are most appropriate. And clearly there will be difficulties around that in other sectors and things, but that's what we've got to do.
Thank you, Professor Little. And again, thanks for sharing your experiences. Hopefully we'll be able to see you back a bit later in the day.
I'll try and make it for your the Dragon's Den type thing.
Yeah, brilliant. Thank you.